Yeah, louder, louder. Okay. Hopefully the Zoom stays on. I'm sorry now that you're going to have two recordings because it kicked me out for some crazy reason. I hope it didn't kick me. I saw it. It popped right up and it said you're out. So hopefully I wasn't talking and I was out for a while. So I've never experienced that, but I think it's because I'm having internet issues. Okay, but I'm recording again, back on Zoom. So here's a little summary of generic brand versus generic. So this kind of sums it up a little bit for an understanding of like kind of what the difference is. You can see active ingredients should be the same. Price is going to be lower for generic. Insurance coverage, if there's no generic available, they just will cover the brand. But once a generic becomes available, sometimes your insurance carrier won't pay for the brand. Sometimes they'll do whatever. They just will pay for whatever you want. It can be a doctor's preference too. Like a doctor might always want to prescribe, the name brand. They just might have a preference for whatever reason. But then, so you may have to ask, say, is there a generic that I can get for a lower cost? Like literally sometimes patients have to advocate for themselves and ask if there's a generic available for a lower cost. Inactive ingredients can be a little bit different. That's where we kind of talked about, Saba, a little bit of tested and approved by the FDA for brand may differ, but still technically proven to be acceptable. And there shouldn't be any, it shouldn't like quote unquote matter. You know what I mean? Like if all things are equal, they should all be acting the same, but they may change things slightly, but they don't think it's enough to be significant. And then strength and dosage should be the same. And then appearance and look, there's usually a standardized for a brand, but the pill can look different if it's generic. So like for the brand, it might always be pink with a 2 and a slash or something on, like the pill always looks like that. But then with the generic, it could be oval or it could be round or it could be octagonal or it could be blue, or so there's like some variation for the way that the actual pill looks when it's generic. Yeah. Yeah, no, in the bottle, or the manufacturer will make them all the same. But one manufacturer to another might make them different. So like you might get a manufacturer that makes a gel tab that's blue and someone else makes a gel tab that's yellow or, whatever. But within that manufacturer, they'll all be the same shape and color. Okay, so classification is another thing to know. Besides the drug name, there's also the classification. And this can also be worded in differently depending on how maybe they have written it on the label, or how if you look it up on a resource, they may call it something different. Like they may call it the pharmacological category, or they may call it the therapeutic effect. It basically just means what is this drug doing? What is this main purpose of this drug? So what's its intended use or its indication? So it might say something like it controls diabetes, or it might say something like it's an anti-diabetic. Those two things mean the same thing. Controlling diabetes, it's an anti-diabetic. It's trying to make you not be diabetic. And then another way that it might say is it might call it an oral hypoglycemic, meaning it's a pill you take orally, and it's a hypoglycemic. It's trying to reduce glucose in the blood, glycemia or glycemic. So it all sort of means the same thing. They just are sort of wording it differently. And I think that can vary depending on the source that you're looking at. But that's basically what the drug classification is it's telling you what the drug is for. So Tylenol is an analgesic. It's a pain reliever. Metformin is an oral hypoglycemic. It's an anti-diabetic medication. So it's saying like what the drug is for. So here's an example. This azithromycin is the generic, and I guess technically I shouldn't have capitalized it just to make it consistent, but azithromycin. So here is how, this is just the drug we're using for an example. Generic azithromycin, that's pronunciation help there. There's many brands. So then you might be like, well, why are there so many brands? All a pharmaceutical company needs to do is tweak something and get it approved, and then they can patent that. So they desperately try to do that with drugs that they have, is tweak something, get that patent, and then market it as a new drug when it's really like just the same drug, just something slightly different. But so that's why, you know, like for azithromycin, something that you might hear very common is, oh, I got a Z-Pack for this infection. You know, so that's kind of a common thing you might hear, a Z-Pack. So but that's a brand name. A Z-Pack is a brand name. What you're really taking on a generic level is azithromycin. So here's, and you can see there's a 3-day dose, there's a 5-day dose, there's one brand called Zithromax, there's another one called Zithromax Z-Pack. Maybe it has something else slightly added to it. I don't really know enough to tell you that, but and then the example of the drug class, it's a macrolide, which is a category of an antibiotic. So azithromycin is an antibiotic, and macrolide is a type of antibiotic. So that's how it's classified, is a macrolide. And another thing that they might say, well, what are antibiotics? Well, they fight bacteria. They either kill bacteria or they make bacteria unable to reproduce. They're harmful to bacteria. So here's some more examples. Xylocaine or octocane, those are brand names. The generic is lidocaine. You'll know that a lot because you'll use it all the time. So generic is lidocaine. Chemical, this is the chemical name. You do not need to know chemical names. The class, what is it doing? What's its intended use? It's a local anesthetic. And then this is how you would see it written on a test or something. Lidocaine is generic. Xylocaine is a trademark name or a brand name. Tylenol, we've talked a lot about that. Acetaminophen, it's an analgesic, that's its class, and then this is how it would be written. When we look at the labels, especially over-the-counter labels, there's several things that should be on a label that have to be there, that these regulatory agencies have made sure that you see the active ingredient. So in each, and there should be details to explain what you have and what you're taking. So the active ingredient in each caplet or each tab or each whatever, there's this many milligrams. This is the purpose or the class. It's a pain reliever. They might use the word analgesic if it's a pain reliever, or they might just say fever reducer pain reliever for, you know, just to use a really lay term that everyone would know what that meant. The uses, it has to say what the main uses are. Obviously, if you may use it for something that's not on this list, but those are the main uses. There should be warnings especially if there's some kind of an interaction that's not safe. Do not use this, blah, 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 whatever that is. There's other information, other warnings, stop using if, you know, they just want to give you all these specific instructions so that you know how to take it safely. So you should always read labels, right? On your food and on your drugs. And then directions for how to take it. So don't take more than directed. This is really important for acetaminophen and ibuprofen. There is a max. And sometimes because it's over the counter and we get so complacent with things that are over the counter, we just take more than we should. I was just in Arizona over break, and Lola gets, she gets growing pains really bad, more than Sadie. And so at least once a month, she wakes up crying in the night because her legs hurt. And of course it happened in Arizona, and I didn't bring children's Tylenol. I usually give her like the liquid grape flavored, and I usually just give her like a third of a dose. And I think it's like placebo effect. I'm like, here's the medicine that'll make your legs stop hurting. And I give her like this much. And she's like, I feel better. So I'm sure she's in pain because she's crying and she wakes up out of a sleep, but a little tiny bit goes a long way. And so, but I didn't bring it. And so I went to that night, I put like heating pads on her. She's like wailing. Her crying is going through the whole house. And I put heating pads on her, and she was eventually fine after about 20 minutes or so. But I went to Walmart and I went to Walgreens, and neither one had one bottle of any kind of Tylenol. Did anyone else experience this? Anyone with kids? So then I texted Kyle. I was like, go to Fred Meyer's. And he sent me a picture. It's wiped out. But I guess on the news, they have said that parents have been giving adults, trying to figure out what a kid dose is. And there's been a lot of kids in the ER with too much OD'd. It's really hard on your liver. And if you don't know like exactly how much is too much, you could easily give a small kid too much Tylenol or yeah, they give you like the liquid is sometimes they have like the baby Tylenol or whatever, and then they have infant, and they're usually pretty specific, like 1.2 milliliters of the liquid, and like once they hit a certain age they can have like 5, but there's a max dose that kids can have that's much less than the max dose that an adult can have. So yeah. I know, it's really freaking scary. Because if they're a smaller kid or a bigger kid, maybe they can have a little more, and totally. So yeah, so that just happened, and I was wondering if anyone else experienced it. So I had some here still, and she hasn't had it since I've been home. But there's been so much, I think, RSV and different viruses, and the supply chain is just. I will not go on about that. We must move on. Okay, so other information, inactive ingredients you can see, and this might be a place where you can see, like, some people have polyethylene glycol, propylene glycol is in a lot of it, and some people have like allergies to that kind of stuff. So, or red dyes. Some people have allergies to red dyes. So, if they have something in the drug that doesn't jive well with you, then that could have, that's why if it's a generic, you could compare and contrast and see what different companies put in. Okay, references. I'm just going to fly through this. These are some lists of references you can use. I have like, I don't know, 10 or 12 drug books in my office. If you want to borrow one, you can. Just make sure you bring it back to me, at the end of the semester, or use it for a couple weeks. But nowadays, most everybody likes to just use the online. This Epicrats, I think they have a app. You can actually get some, like a lexicon maybe even has like an app you could put on your phone. Of course, you have it in clinic. You all are familiar with that by now. And these are just all different resources that you can use. So, okay, drug administration. So the three main ways that a drug gets into the body is enteral, parenteral, or topical. And within those, each one, we have subcategories. So we'll talk about each one. So enteral administration involves the GI tract. So from the front door to the back door, anything that goes in that mechanism through the GI tract is considered enteral. So just because it goes in your mouth doesn't mean it's enteral. So it has to go down and be involved in the GI tract somewhere, or it could be a rectal suppository and it could go in the other way. So if it's involved in the GI tract, then it's enteral. So oral, another way to write that on like a prescription pad is PO, and that means it's been swallowed, right? So it's not just oral as in it's in the mouth, it has to have been swallowed. And then rectal is PR, and that can be that you'll see that more like with kids. If their stomach is too upset and they can't swallow a pill yet, there are some medications that they'll do suppositories, or if they're having trouble going to the bathroom or something like that. But there's also medications that can be delivered rectally. Those are common routes for kids. Yeah. Oh shoot. Don't ask questions I don't know the answer to. We'll look it up. Someone look it up. What does PO stand for? Oh, by mouth. By mouth. There's, okay, yes, that's it. That's right. because we go over some of the prescription writing, and so like BID or TID, they all stand for, and I think their origin might be like Latin or something like that, and I don't know. We go through a little set of things that you need to know. But yes, that is absolutely right. By mouth, and I don't know why it's PO. Maybe the original words start with a P and it's Latin. I don't know. We'll get to that point later. But that's a great question, Esty. Okay, so the next route is parenteral administration. Drugs delivered via a needle into a skin layer. So the needle is angled at different angles. There's a picture coming up where you can see that it's angled at different, someone who's like a phlebotomist or something, they'll know, the different ways to get into a vein or how to, or nurses or something, they'll know. Yeah. Did you? Per os. By mouth is like the English. Yeah. So it's all Latin. It's all Latin based. So and there's a little section that we do our prescription writing, because you guys do have the ability to write prescription for fluoride and even some analgesics like NSAIDs and anti-inflammatory medications and fluoride and what was it? Chlorhexidine. Yeah, so there are a few prescriptions you can actually write. So we do go over that a little bit in a little bit later. Okay, so I'm not going nearly as fast as I need to go. So these are the different ways to administer by a needle. So IV, everybody knows IV, that's right into the vein. If you put a medication straight into the vein, you've gone straight into the circulatory system and away it goes. Other ways, it has to diffuse, it has to absorb. But if you put a medication into the circulatory system, you're going to get the fastest reaction of a drug directly into the circulation, into a vein. IM, intramuscular. I think vaccines go intramuscularly, right? Subcutaneous, sub-Q, into the connective tissue under the skin. Intradermal, into the dermis layer. I think, if I'm remembering right, like the TB test is intradermal, yeah. And then intrathecal, like a spinal or epidural, maybe perhaps the same thing. So that involves this spinal fluid. And then intraperitoneal, I looked this up. This was new that I added last year and I couldn't remember what it was. So I looked it up again, and basically it means into the body cavity. So I wanted to take out local anesthesia because I was like, huh? But I guess, technically we sort of are going into the body cavity. We're going into an area. We're not going into a vein, right? Or an artery, or we don't want to, because then we'll get a hematoma. We're just kind of going into this space, right? That's like close to the nerve. So I found that last year, but when I went to review it and be like, what did I mean by this? I couldn't find that exact thing, but I did find chemotherapy, and then they use it a lot. This is much more of a common term of an administration in veterinary medicine. So a lot of times I think they like pull up the animal's scruff and they put it in. So that's more, and you're not going to be tested on that. You can see I wrote not on the test. So that's sort of just an additional one that I had found that I added. So here are the visuals for the different intramuscular, subcutaneous, intravenous, and intradermal. You can see that the needle is angled differently. We don't really do any of this, right? So we don't have to be proficient at it, but it's interesting to know in the different layers of tissue. And then the last one, so we have enteral, parenteral, and topical. So topical administration of drugs is directly in the surface of the body where the action is desired. So it's more localized. So an inhaler goes directly into the lungs, so that is considered topical. Yeah, there are some systemic effects to it, but that is considered topical. A patch, like a Nicoderm patch, that's considered topical because it's transdermal. It's right there on the skin. Buccal, if you hold something in the cheek, between the cheek and the tongue. Sublingual, so like a nitroglycerin tablet for someone who has angina, that dissolves under the tongue sublingually. And it does go into the bloodstream, obviously, but it's a topical administration. So all of those are considered topical administrations that then go into the system and are effective. Yeah.
If you do like a pill and put it up and let it dissolve, is that still considered?
That's probably considered topical. If you're letting a pill dissolve under the tongue, that's considered topical. No, even if it's meant to be swallowed, like some people I know like hold aspirin. That's an old thing, like an older thing I think people used to do, but that's I think still considered topical.
If they don't want to for like calcium, they would bring their other pills in and they still.
Oh, interesting. Yeah, it right into the bloodstream faster than having to go into the stomach, into the small intestine. Interesting. Okay. Now the fun begins. I know your brains are already probably done, but now we got to get into some harder shit. So, terminology: pharmacokinetics, pharmacodynamics, pharmacogenetics, pharmacotherapeutics, and toxicology. We're going to talk about each one here. I want you to know these definitions in a very, very easy way. I'm sure that all of this is more complicated if you're a pharmacy student. We're not pharmacy students. So I just want you to understand this in a very basic way. So if the word, because you will get tested on these terms, so you need to know what the terms mean. If you see the word pharmacokinetics, all you have to know is what should trigger in your mind is what is your body doing with that drug? What is your body doing with that drug? When you put that drug in your mouth and you swallow it, and it goes from here to there and absorbs here and gets metabolized there and gets excreted there, that's your body doing stuff with that drug. It's gone on a little mission, and then you have metabolized it, and now you've excreted it, and now you need another pill because it wore off. So that was your body doing something. So the way the body affects the drug is another way of thinking about it. But if it helps you to remember the difference between the two, one is how your body kind of handles it, and the other one, the opposite, pharmacodynamics, is what that drug is doing to your body. So it's going to stimulate stuff. It's going to block stuff. It's going to reduce inflammation. It's going to decrease blood pressure. That drug is doing something to your body. And the way it does it is it interacts with different receptors. That encompasses things like the dose and how the relationship of how high the dose is. But those are the two. That's an easy way to kind of separate those two things. And if this helps, kinetics, what's kinesiology or kinesiology? The study of movement. So that might help you also remember the drug is moving around your body. It's going to be swallowed, it's going to be absorbed, it's going to be metabolized, it's going to be excreted. So that might also help you remember the definition of pharmacokinetics. Kinetics, movement, that's another cheat. But just try and think about those in like simple definition terms, and that should help you for exams and stuff to remember what's what. Pharmacogenetics, it kind of gives it away. It deals with genetic factors that influence an organism's response to a drug. So genetically, we're all a little bit different. And so some people need higher and lower doses depending on our genetics. So it's sort of the study of that. Pharmacotherapeutics, it's just studying how drugs benefit us through the therapies that we're trying to, the benefits, the disease improvement and, handling different stuff. So therapeutics. Study of the drug prevention, diagnosis, and treatment, and then toxicology, like toxic, right? The study of how the chemical pollutants, understanding undesirable effects, how a drug could potentially be toxic, what's too much, this sort of thing. How could it potentially toxically affect our cells and our tissue? Okay, so back to the beginning. So now we're just gonna go through each one in a little bit more detail. So pharmacokinetics, study of how a drug enters the body. So here's that kind of movement concept, how the drug enters the body, how it circulates around the body to reach its target organ, right? So when you take an ibuprofen, you want it to work on your, sore ankle or your headache or something like that. But when you swallow it, how does that chemical agent get to those receptors to actually dampen that pain, right? So how it reaches the target organ and then how it leaves the body, because you don't just want ibuprofen circulating in your body for all eternity. Your body actually breaks it down and gets rid of it. So ADME is the little acronym to help you remember these 4 steps: absorption, distribution, metabolism, and excretion. So you have to know those as well. That'll be a test question, and I'll mix it up a little bit, but you want to actually know. And so you just think about logically, like what's happening. I've taken a drug. It needs to be absorbed, and then it needs to be distributed to get to where it needs to go. My liver is gonna break it down, and then I'm gonna pee out the non-useful part as I break it down. So you're gonna think of those 4 steps. I'm gonna swallow it, move it around, break it down, excrete it. Okay, I hope I have time for this. This is like 4 minutes. No, it's just a little video. Is there no sound? Oh,
For body brain negative. But how does it get where it needs to go in the first place? The answer is that it pitches a rise in your circulatory bloodstream, cycling through your body in a race to do its job before it's snared by organs and molecules designed to neutralize and expel foreign substances. This process starts in your digestive system. Say you swallow an ibuprofen tablet for a sore ankle. Within minutes, the tablet starts disintegrating in the acidic fluid of your stomach. The dissolved ibuprofen travels into the small intestine and then across the intestinal walls into a network of blood vessels. These blood vessels feed into a vein, which carries the blood and anything in it into the liver. The next step is to make it through the liver. As the blood and the drug molecules in it travel through liver blood vessels, enzymes attempt to react with the ibuprofen molecules to neutralize. The damaged ibuprofen molecules, called metabolites, may no longer be effective as usual. At this stage, most of the ibuprofen makes it through the liver unscathed. It continues its journey out of the liver through veins into the body's circulatory system. Half an hour after you swallow the pill, some of the dose has already made it into the circulatory bloodstream. This blood loop travels through every human organ, including the heart, brain, kidneys, and back through the liver. When ibuprofen molecules encounter a location where the body's pain response is in full swing, they bind to specific target molecules that are part of that reaction. Painkillers like ibuprofen block the production of compounds that help the body transmit pain signals. As more drug molecules accumulate, the pain-canceling effect increases, reaching a maximum within about 1 or 2 hours. Then the body starts efficiently eliminating ibuprofen, with the blood dose decreasing by half every 2 hours on average. When the ibuprofen molecules detach from their target, the systemic bloodstream carries them away. Back in the liver, another small fraction of the total amount of the drug gets transformed into metabolites, which are eventually filtered out by the kidneys in the urine. The loop from liver to body to kidneys continues at a rate of about 1 blood cycle per minute, but with a little more of the drug neutralized and filtered out in each cycle. These basic steps are the same for any drug that we take orally, but the speed of the process and the amount of medicine that makes it into the bloodstream varies based on drug, person, and how it gets into the body. The dosing instructions on medicine labels can help, but they're averages based on the sample population that doesn't represent every consumer. And getting the dose right is important. If it's too low, the medicine won't do its job. If it's too high, the drug and its metabolites can be toxic. That's true of any drug. One of the hardest groups of patients to get the right dosage for are children. That's because how they process medicine changes quickly, as do their bodies. For instance, the level of liver enzymes that neutralize medication highly fluctuates during infancy and childhood, and that's just one of many complicating factors. Genetics, age, diet, disease, and even pregnancy influence the body's efficiency of processing medicine. Someday, routine DNA tests may be able to dial in the precise dose of medicine personalized to your liver efficiency and other factors. But in the meantime, your best bet is reading the label or consulting your doctor or pharmacist and taking the recommended amount with the recommended time.
Okay. So that's, you can re-watch that. I always think that like once you've studied a little bit and then you re-watch stuff, I feel like, I don't know if that's still being shared or not. I'm just going to stop share and then go back in and share it again. Once you kind of have a base knowledge and then you rewatch things like that, I feel like it kind of helps with understanding. So I liked that video. I thought it kind of stayed pretty close to kind of what we talk about in this with the PowerPoint. So that's there for you. Okay, so to reiterate what was being discussed there. So when we talk about absorption or the series of activities that a drug goes through, you'll swallow a drug, it goes into your stomach and starts to dissolve there. And then it can get absorbed in the stomach and then go into the circulatory system, or chances are, because things usually move through the stomach pretty fast and it might take a while for something to be absorbed, things most often get absorbed in the small intestine, but that's not, there's just, I'm not going to quiz you on, does that drug get tested? Is that absorbed in the stomach or the small intestine? Like that specifically isn't going to be asked, but there is a more broad question that may be related to that. But I'm not going to ask you that on like every medication. That's not something you need to know. But so things either get absorbed in the stomach or the small intestine, and then it goes into the circulatory system or the bloodstream. And then it just goes through a cycle of going through the liver. Some of that medication gets captured by the liver and gets turned into a metabolite that the body can't use that anymore as the purpose of the drug that it was originally intended for. So every time it cycles through the liver, some gets captured. What doesn't get captured keeps going through the body, and whatever part of the body needed that drug, it binds to those receptors on that part. So if it's like a drug that's supposed to stimulate insulin, that drug has an affinity for receptors that are going to help to produce insulin. So it's going to go to that area, and it's going to in pancreas, and it's going to try and stimulate insulin production. So it's true for any drug doing anything. So they have specific binders, and so it's just going to go through the body and keep going through the liver, and then usually excreted through the kidneys, but it could be excreted through other ways. It can be like exhaled, or it might be like out of a bowel movement or something. So yeah.
The long-term damage to the liver is that due to like the production of too many
I think, I don't know like specifically on a chemical level like what's happening, but it's probably like that's actually a really great question. I don't even want to answer that until I've looked, because I could speculate, but I actually don't know. Some things become toxic after too much time, and it's obviously your body just can't handle the metabolizing of it. So whether it's from the enzymes or the metabolites, I actually don't really know, but that is an excellent question, which I now want to know myself. So I'll look into that maybe, and then we can talk about it next time, because that's really interesting. Because you know that people who are heavy drinkers and they get some cirrhosis of the liver, or if there's fatty liver, different things that affect the liver, it's gonna affect how they metabolize drugs, and they can have more toxicity issues. And so I'm not totally sure what's happening on a small level. Absorption, so molecules are transferred from the site of administration, circulating fluid. This is how drugs penetrate. So now we're going to talk about how drugs go from the stomach, the small intestines, into the circulatory system. How do they actually get into the bloodstream? So here we have kind of a blown up version of, we have sort of a blown up version of cell membrane, or and we have, our cell membranes are everywhere, right? They're compartmentalizing, separating organs from organs, veins and arteries. It's encasing everything inside of our body. And for the most part, for what we need to know for this class, when you look at it, we're looking at this lipid bilayer. So it's mostly lipids. So anything that's likes lipids or is lipophilic will passively absorb through that layer. If it's, remember those terms, hydrophobic, hydrophilic. If it's hydrophilic, it likes it. If it's hydrophobic, it doesn't like it. And so if it's lipophilic, we're going to have, there's a lot of surface area for a drug to just sort of passively go through that cell membrane. And then there are these water ion channel aqueous pores. And if a medication tends to be more hydrophilic, then it's going to have to sort of passively percolate through there, but there's not as many of those pores. And then other things are going to vary, like the size of a molecule, the pH of the environment, things like that. But something has to be lipid friendly, really, in order to get through these barriers. So that's how our body kind of protects itself, is a lot of things that enter your body are not lipophilic. They're just naturally not. And so that's kind of our natural defense system. I'm all of a sudden very phlegmy. So here's another example. You can see like A, for example, this drug A, the D's are supposed to be like a little drugs, little D's. So drug A is very lipophilic, and so it's going to passively go from an area of high concentration, the stomach or the small intestine, to an area of low concentration, which is the bloodstream, and it'll just sort of passively diffuse through the cellular membrane. Drug B is highly ionized. That's what all the little pluses are for, and we'll talk a little bit more about that in a second. It's not lipophilic. It's probably maybe hydrophilic. I don't know. We'll just call it hydrophilic. So it's not going to passively diffuse easily. It's going to stay in this area of high concentration. So how does pH affect this? So there's not a lot that there's probably, again, I always like to say this because we just need to know what we need to know. And sometimes you guys have the best questions that go beyond what we need to know. And I think it's always good to think in those terms and think beyond. But there's probably more to this topic than what I present here, but this is what you need to know. pH affects the absorption. And so we just need to understand that when we talk about pHs, we're talking about weak acids and weak bases. And we know the pH scale, you know, the 1 to 14, and neutral is 7. So if it's a weak acid, it's going to be somewhere between, you know, whatever 2 and 6 or something like that is considered weak acid. And if it's a weak base, it's going to be somewhere between 8 and 10 or 8 and 12 or something. If it's the farther on the ends, the stronger the base and the stronger the acid. So it's somewhere in that range, right? And drugs are present in the solution. So once it breaks down, or once it breaks down into our bodies, it's either going to be in an ionized form or in a non-ionized form. And all you really need to take away from this is that which form is going to be easier to absorb and which environment is going to affect it. So it's pretty limited what you need to know. This might sound like it's going to be kind of scary and complicated, but it breaks down pretty simple for what you need to know for exams. An ionized form, if it's ionized, it's low lipid solubility. And so it does not, so then you can think of it as having all those pluses. It's got something added to it. It's ionized. It's low lipid solubility. We already know that the cell membrane is lipid. So if it's low lipid solubility, or lipophilic or lipophobic, I guess you could call it, it's not going to absorb easily. If it's non-ionized form, it's going to absorb better because it's going to be more lipophilic and friendly for that lipid bilayer and absorb passively through the cell membrane. So ionized form doesn't absorb so great. Non-ionized form absorbs pretty good.
Are both of like the ionized and
like sort of the single, like, Tylenol, like they have both.
Yeah, so some drugs are going to be more of more of an acidic drug or more of a basic drug. And so depending on kind of where they are can affect it. So like the stomach, would you consider your stomach acidic or basic? Acidic. So if the drug tends to be more of a basic drug, it's not going to absorb well in the stomach and it'll just keep going. But your intestines is more of a basic environment, and so it'll absorb more in the intestine. So that's the takeaway. There's not a lot more and we'll get to it in the next slide.
The origin rather than
It's more about the environment than the drug. The drug kind of comes in a state, like the drug is either more acidic or more basic. Local anesthetic, does anyone know what local anesthetic is? It's more, just by itself, it's more basic. But inflammation makes an environment acidic. So if somebody has like crazy inflammation, it's harder to get them numb because the absorption of the local anesthetic is harder because it's more basic. So pH, when we talk about pH, we're talking about hydrogen ions, concentration. We don't need to go into super deep depths about it, but that's basically what we're talking about. Here's some examples of what I said, like the weaker acids or the weaker base. We're not totally on the end. Those would be strong acids and strong bases. We're kind of closer to the neutral part. And drugs are absorbed when they're mostly in their non-ionized. That's important to know. You can highlight that. Drugs just won't be absorbed as easily or as readily or as quickly. Will they be absorbed some? Probably, but that's kind of getting more into the weeds. In general, if it's in its non-ionized form, it will be absorbed better. So weak acids absorb in the stomach better. If it's a drug that's a weak acid, it'll get into your body through the stomach better. If it's a weak base, it'll get into your body through the intestine better. Yeah. Yes. So the pH is based on, the drug comes at sort of a pH, like it just comes when you have the pill, it's already sort of a pH. It already has its own little identity. And then, but when you take that pill and you have to match it up to the environment that it best suits, that it best will be absorbed through. So you'll take your pill and if it enters an environment that's very opposite from it, if it's acid and it enters a base, it's going to become more ionized. So it's not like it has an ionization status. It will become more or less ionized if it enters an environment that's different from it. So if an acid enters a basic environment, it'll become more ionized. If an acid enters an acid environment, it will be non-ionized. But I think the drug itself comes at a pH level, like it's already packaged that way. It's just either this or that. It's either more acidic or more basic. I am totally going to run out of time for this, I'm pretty sure. So we will but the lecture next week is shorter, and so I'll just pick up where I get, but I'll just keep going. Oh, because there's a quiz next week. So I'll just make sure that wherever we end today, that's where the questions on the quiz will end. Yeah. Okay, so here's just an example with aspirin. So aspirin comes packaged as a weak acid. That's just aspirin's identity. They are weak acids. And so a weak acid will simply absorb better in the stomach. This is the stomach lining. It's going to be more non-ionized, and it'll simply absorb better in the stomach than it will in the small intestine. So it's just showing how it's bouncing off this cellular membrane, this lipid layer is just kind of not absorbing as well in the small intestines. It does most of its absorption. Now, there is more truth to this that doesn't just fit into this box. This box is really oversimplifying it. And because things go through the stomach very fast and they spend more time in the small intestine. So this doesn't mean that there is no absorption, but this is just for you to understand this basic concept of ionization, non-ionization, absorption is more ideal when it's matching up the environment and the acidity are matching up. So we're kind of oversimplifying it for this course. I think if you were a pharmacist, it would sound probably very different. Yeah. But yes. Yeah, well, and some things like milk can bind up something, grapefruit can creates more enzymes, and they say don't take grapefruit with this medication. So food and drugs can affect medication. So yes, if they give you a specific thing like eat this with food, don't have food, don't avoid orange juice or, avoid grapefruit juice or whatever it is. Yeah, no milk with tetracycline or whatever. Oh yeah. Don't, and that's a perfect drug interaction. So for a summary for that, drugs are absorbed into the blood in their non-ionized form and when they are in a lipid suitable form. So when they are happy to be more lipophilic, they're not, and if they're more lipophilic, they're going to just naturally be more non-ionized. That's just the state that they're going to have. Yeah.
So aspirin being a weak acid is considered an ionized drug.
So when you have a drug in your hand, you're like, here's my drug. This drug is ionized. This drug is not ionized. So it's not like that. It's more like once you take it into your body,
it will be ionized.
It will either become ionized or non-ionized based on the environment.
And then typically aspirin, once it enters your body, is more ionized.
It's non-ionized in the stomach. It likes the stomach because the stomach is acid and aspirin is acidic. So it likes that environment. So it's more non-ionized in the stomach. It becomes more ionized in the small intestine because the small intestine is more basic.
Because some of it will pass through to the small intestine and
yes.
get absorbed that way.
Yeah, just much slower.
Okay.
And much more difficult.
And then it becomes ionized once it's
yes. And that could be reversed if you're dealing with something that's more basic, so the drug doesn't come either ionized or non-ionized for our learning purposes, but it will become that in the environment. Yeah.
So I just wanted to hear something else from the aspirin. Are we saying that because it's acid, it will absorb it better in the stomach?
Yes.
But in the small intestine, it will absorb more because of the surface area?
So it's not that, so there, I don't know if it's in the notes, but I don't want it to confuse you. The first thing you said was very true. It will absorb better in the stomach because the stomach is acidic. But just because of the law of surface area and how long something stays in the intestine, there will be some absorption, even though it's not ideal and it won't do it as easily as it does in the stomach. There will just be some absorption that happens, but that kind of gets into the weeds and it kind of confuses. The main point that I want you guys to grasp on is if it's an acidic pill, it will be non-ionized in an acidic environment, therefore it'll absorb better. So that's what I want you to take that home. But like I said, there are other truths, like it will continue on to small intestine and there probably will be some absorption, but that could throw you a little bit. That could confuse the main point that I want you to know, let's go over these summaries real quick before we run out of time, because this kind of will hammer it in. So a highly ionized drug cannot pass the lipid membrane. So ionization will impede absorption. Non-ionization crosses the lipid membrane freely. Most drugs are either a weak acid or a weak base. They just come that way. Out of the box, out of the pill bottle, they just come that way. For weak acids, the more acidic the environment, the more non-ionized, the better it will absorb or pass through that lipid layer. For weak bases, the more basic the environment, so we're talking about the environment is your body, the more non-ionized, the more easily it will cross. Bases are most highly ionized in an acidic environment, and they're not absorbed well, and vice versa. So if it's the opposite, if it's a basic medicine in an acidic environment, it's going to become more ionized, more highly ionized. So here's the way this works. How much time do we have? 3 minutes. So the way this works is you can ask yourself this will just help you memorize it. I would rewrite these I think it'd be more helpful if you like rewrite it. So where is, instead of it, put in weak acid. Where is weak acid, or where are, I guess are maybe should be the right word. Where are weak acids most ionized, question mark. So then you would say a weak acid is most ionized in an acidic environment / the stomach. And then I don't understand why I have, is that good or bad? I think the question is, that would be good, right? Because it's actually being absorbed. And then if you change it and you put where, no, I don't understand the good or bad part.
I think it is the absorber.
I don't know.
What you said, ionized, so if you see the acid is most ionized in a, like, in the intestines, so it's not basically in the intestines,
Mhm.
so that's bad, because it's not saying it's good.
Yeah. Oh, because you can put in either one. So that's okay. If you guys can figure out the question that I came up with and can't remember what my point was, that's great.
I just thought that we wanted to be more ionized or non-ionized, so when it says non-ionized, that's good.
Yes,
If it says ionized, it's bad.
that's true. If it's non-ionized, it's good and in order to be non-ionized, the environments have to match up.
Because
If-
it won't be absorbed.
Mhm.
'Cause
If
can't
it-
go across the membrane.
Exactly. And if it's ionized, it's bad because it can't cross the membrane as readily.
So I think that's what,
That's probably what I meant.
because you didn't actually write weak acid in the sentence, and that's probably why. I think when you
Yeah.
add weak acid into it,
I know. When I looked at it last time, I was like, I should take that out because I don't quite know what I mean, but I didn't. Okay, so I have 2 minutes. I'm just gonna leave it. I'm gonna leave it there. So the quiz on Tuesday, next Tuesday, the quiz next Tuesday will just go up to that slide. It will just go up to slide 43. So that's everything from the beginning until slide 43 will be on the first quiz. And so we'll do the quiz first, we'll finish up this, and we'll do the oh lordy, it's gonna be tight, but I just really want to do it before we talk about, I really want to do blood glucose. What do you guys have after this class? Perio? Okay. So yes, so we'll do quiz, we'll go through the rest of the material, and then I think if we have it, I think we can all do it in a half an hour. I think that half an hour should be plenty of time, because 15 minutes for you to take it on your partner, and then for 15 minutes for them to do it on you. So we should only need a half an hour to practice blood glucose. So we'll just have to get to work and like make sure we get it done, because I do want to do it next week. So we have more time on the following week to like review concepts that are murky for the exam and go over the endocrine system really without feeling rushed. So, all right, that's it for today, you guys. Thank you. Yes, you're welcome.